Welcome to the Academic Life in Emergency Medicine, Journal of Graduate Medical Education, Hot Topics in Medical Education Virtual Journal Club. Wow, that was a bit of a mouthful. I'm glad that you can be joining us if you're watching at home. A shout out to the Harvard Macy Institute that I know is watching as a group. We're delighted that we can fit into your week-long learning activities. This is the second year of the Hot Topics in MedEd, where we attempt to have a global conversation about an article published in JGME that we think has a general appeal to the medical education and health professions education communities. The opportunity to discuss the paper over the course of the week via our host webpage discussion board, via Twitter, is really exciting. It's a way to engage a whole range of perspectives rather than finding ourselves limited by physical restrictions. For the next 45 minutes, I'm delighted to have the first author and one of the co-authors of the paper join us, as well as a medical education and health professions education expert comment on this paper. But before we move to that, just a brief introduction. My name is Jonathan Sherbino. I am an emergency physician and a medical educator at McMaster University. You've probably heard enough from me, so let's introduce some of our contributors today. The first author of the paper is Sandy Balwan. Sandy, please say hi and introduce yourself to our audience.
Hi everyone. Thank you for joining us. My name is Sandy Balwan, and I worked on this paper, among others, with Dr. Alice Furnari, who will introduce herself in a second. At the time I wrote this paper, I was the associate chair for the Department of Medicine at the former North Shore University Health System, now recalled Northwell Health. Thank you for joining us.
And next we have one of the co-authors of the paper, Alice Furnari. Alice, please say hi.
Alice Furnari. I'm a Harvard Macy alum, and I'm so excited they're watching. I'm also faculty in Harvard Macy, so hello to my Harvard Macy world out there. This paper, for me, was exciting as a medical educator. I'm not a physician. I'm a doctorate in education, and to have a group of physicians come to me and say, we really need to change our ambulatory teaching with residents. What do you think we could do to make it more active and not passive? So as an educator, I got involved with my team of physicians to work on the ambulatory curriculum in internal medicine. My role is Assistant Vice President of Faculty Development for the entire health system of Northwell Health now, which is 21 hospitals and many residencies. Plus, I'm an Associate Dean at the Hofstra North Shore School of Medicine, which in that role I do pretty much faculty development, educational skills development, and I co-direct the communications curriculum for the medical students.
Thanks, Alice, for joining us. I know that it was challenging to fit us into your schedule. And finally, from the University of Ottawa, Ali Jalali. Please say hi.
Hello everyone, I'm Ali Jalali. I'm really glad to be here. We've been doing team-based learning at University of Ottawa for a decade now. I'm the professor of anatomy and teaching chair around here, and we've been using it in undergrad. I was very excited when I was invited to participate because this is one of the first time I hear about this in postgrad. So excited to be here.
Great. So if you've had a chance to read the article, that's excellent. If you're still looking for it, you can go to the web page where JGME has made it free access. To catch you up to speed for our discussion today, Sandy, I was hoping you'd give us the elevator pitch in 1 minute or less, although we don't really have a clock watch. Can you describe your question and the findings from your study?
So thank you, Dr. Gelati. It's really nice to know that you've been doing this for a while. And we actually got the idea of doing this in our graduate medical education, specifically our internal medicine residency, because we know there was literature out there in the undergrad arena, but we wanted to try it in the graduate arena. So what we did is that we completely transformed our ambulatory education curriculum from a traditional didactic case-based session into a TBL curriculum. What was unique to our program is that we moved to a 4+1 module schedule. So in other words, every fifth week the residents rotated from the inpatient setting to the outpatient setting. And so we found that it was a great opportunity to have continuity with that group. So what we found is that as we revamped our curriculum and implemented the TBL, we found the residents to be extremely engaged. Satisfaction with ambulatory teaching was significantly more, and that satisfaction rang true for both faculty and residents. we found it to be more engaged, and found the sessions the residents felt that they learned more.
Excellent. Alice, any further thoughts on the design of your team-based learning sessions and
So
why?
as a medical educator, and I don't know exactly how Ottawa does TBL, if they do this, sort of purist TBL format, which of course is well established at Wright State in terms of their implementation of TBL by Dean Parmalee and of course others. But I think what was important for me as a medical educator is that healthcare professionals work in teams. That's how they work, so they should learn in teams. So team-based learning seemed to be a natural pedagogy to transform the ambulatory teaching. Because if they learn in teams, it will be more meaningful, just like working in teams is more meaningful. The patient care outcomes are better, and here the learning outcomes are better. So this idea of TBL to me was just a wonderful marriage at the residency level. The complexity of delivering the true purest TBL to the residents due to the residents' time schedule, the amount of time allotted for teaching, the frequency of the teaching, made us really be a flexible learning environment to adapt the TBL, even though the core principles we kept. The very core principles we kept, but there had to be some changes in terms of schedule and group formation and things like that. So I think as an educator, my message is you have to have a little bit of flexibility sometimes to transfer a pedagogy from the undergrad to the GME level of learning, but it doesn't mean we have to abandon it at the GME level.
Great. Before we turn to our journal club questions, I was hoping we get some behind the scenes. I'm a big behind the music kind of fan. Behind the scenes anecdotes about something that was interesting that you learned personally during the application process or during the publication process. Sandy, anything you want to share?
I think I wanted to share with you my excitement in seeing this come to fruition. Again, it started with a conference I went to, the Association for Program Directors in Internal Medicine, where they were doing this in the undergraduate arena, and I thought, how could we modify this to our outpatient arena and for the graduate arena as well? And the first time we did it, the first week, the very first session, I was just amazed at the buzz in the room. So much so that I was motivated to grab a camera and just record that buzz. And for me, that was significantly rewarding. And that really gave us the motivation to keep this going and to do whatever we had to get this complete and get buy-in from faculty and residents.
Alice, anything that you want to share with us about behind the scenes?
I think what I said before, as a non-MD educator with physicians, to be able to excite them about redesigning curriculum with pedagogy, to me, is a gift as a medical educator to be in that situation and work with colleagues who are truly dedicated, not to just, okay, we need to deliver 6 topics, we'll deliver it, doesn't matter how. They really wanted learning. So I think that for me, that was the most exciting time, that all the time we spent together knowing who they were and where they wanted to go was really the best part for me.
Cool. Excellent. So let's turn to our first question. The cognitive psychology literature would tell us that how we learn is really influenced by the environment, the individuals around us. Having said that, how do we structure our teams? If they're idiosyncratic, the experience is going to be different and potentially our learning is going to be different. Should we structure a team randomly, or should we be thoughtful and intentional in determining the design and the makeup of the different individuals? How did you guys approach it?
So for our team formation, we actually assigned a team ahead of time. We tried to make it equal teams, and that there was a PGY, an equal amount of PGY, 3, 2s, and 1 in each team. And the important thing about those teams is that they remain permanent. And the idea behind that was that for a team dynamics to occur and for a team to gel, it takes time. So to constantly change that team, I think it would take away from that dynamic. And so for us, it proved successful to maintain that team the components of that team throughout the year, throughout the 3-year curriculum.
Ali, you've used team-based learning at University of Ottawa. How do you structure your teams? Do you have a thought or a preference as to the best approach?
We do the same thing. I mean, it's one of the principles of team-based learning that the team formation needs to be very, precise. So you need to have people from all levels that are in each team. So for us, we have people who have done anatomy all the way to the people who have never had anatomy before, in anatomy lecture I'm talking about. So it is very important, and as it was mentioned by Sandy, it needs to be for a long time. You just don't want to form groups. And it comes back again to collaborative learning, right? You want to start collaborating with each other and help each other learn with constructing the knowledge and, helping with that working memory and all that. I'm sure Alison can explain these much better than I can, but, the idea was they need to feel like a team so they can help each other learn better. So the team formation is an important part of it, and we make sure that the teams are well balanced from people who know about the stuff all the way to the people who have no clue what's going on.
Alice, one of the questions we've had this week on the virtual journal club is, does a team need to be sustained for a long period of time, meaning over the course of a month or as the rotation progresses, or should a team be constructed and deconstructed on a weekly basis? Is there advantages or disadvantages to either approach?
So I think in terms of teams, why do we form teams? We form teams to form relationships and to share expertise, to share, which is from knowledge and skills and past experiences. And the only way to do that is to have some relationship. So you don't want to have, different teams all the time. You want the teams to have enough time to solidify, and when they regroup, it's not a fresh situation. There's a past history to that. So even though our teams were not over a semester, like in anatomy, you might have, 14 weeks of the same teams, we were not able to do that because of the way the residency structure is, that they're in the ambulatory setting, 4 in the inpatient, 1 in the ambulatory. But we were still able to get a team dynamic going within the group that was in the ambulatory on a repeated process. So I think you have to have some continuity. It may not be daily, it may not be weekly, but there is still a sense of relationship and ability to not be starting from scratch each time a team forms.
I agree that storming and norming process of team dynamics requires time and investment. Let's transition to my next question. Sandy, there was, from the results of the program evaluation, a conflicting message, or at least a conflicting message as I interpreted it. When asked individually, both faculty and the resident participants on a survey endorsed very highly, over 90%, that each individual contributed, in air quotes, their fair share. But through the nominal technique, where almost a group consensus process was adopted, reflected that one of the weaknesses of team-based learning is that there was discrepancy or misrepresentation of how much each individual contributed. The perception being that there were some who did a lot and some who did far less. How do you reconcile this difference, and where does the truth lie?
So I think it comes down to what was the minimal requirement. In terms of minimal requirement, they were each assigned ahead of time questions to prepare for, and they knew that for questions or learning objectives 1 and 2, for example, person X was responsible for that. So that person coming to the session, having prepared for those sessions, that was a minimal contribution for that person. And I guess the resident perspective, someone who did not contribute would be someone who really did not prepare at all and came in with nothing to the session. In terms of the richer discussions, though, and I think this is where personalities play a big role, people who speak up and talk and are willing to share, comfortable with public speaking, those are the ones who probably gave more than a minimum requirement, and the others who just, did what they had to do, came prepared, did what they had to do, but that was all they gave. I think that was the difference. So you had people who were, great talkers, loved sharing, loved learning, and really were willing to extend themselves and contribute a little bit more.
Excellent.
I just want to say something about the peer. I think equal participation among teams is always, you know, some people who are more aggressive and other people who listen more passively. But it's a peer collaboration in a team that allows somebody who maybe is being a little quieter for the peers to bring them out. So that comfort we spoke about with the team should help to make team dynamics more even across teams. Peer evaluation is very powerful to peers. So I think it's something to work towards, even at the GME level, is more peer evaluation to have more successful teams, either clinically or learning.
Ali, Alice has talked about peer evaluation, social pressure. How have you dealt with the experience of individuals who come to a TBL session unprepared? That's been some of the debate that we've found online this week as to how do you deal with these individuals, or is it really the function of the faculty facilitator to address it?
No, not at all. Accountability is one of the most important principles of team-based learning. Accountability is at different levels, right? As you guys were talking, I was wondering if you guys use the scratch card for your GRATs or not. One of you answer that? Did you guys use this scratch card for the GRAT or not?
No, the if-at cards, no, we did not use those.
Yeah. So there you go. So that's when, the scratch card in the team-based learning, that's where it's supposed, for those people who don't know, when you do the IRAT, you do an individual test of your knowledge of what you prepared before coming. And when you do that GRAT, which is a group-ready assurance test, is when as a group you decide on an answer. And you can only choose one answer at a time. And each time you choose an answer, if it's wrong, you're losing point. Actually, that's there to take care of the people who are extrovert, who think they're right all the time, right? Because let's say you have 20 questions, the group starts and say, okay, what do you think the answer to A was? And the guy who talks all the time, he says, I know for the question number 1 was B. I know it. And then you scratch, but it's not B. So your group already lost the point, right? This makes that individual realize that he can't be that sure of his answers, and maybe the introverts get a chance to talk also about it. So by the 3rd or 4th question, if your introvert person who never talks is giving the right answers, you will see the group shift toward her or him, asking her, you got the last 3 right each time. Can you tell us what did you put for this? So GRAT is supposed to take care a little bit of this group imbalance for the extrovert or the people who are, sure of themselves that talk, and then against the others who can't. Now, to tell you the truth, as Alice mentioned at the beginning, I have modified team-based learning. So I neither don't do the GRAT because you cannot do everything, but I do a group discussion after the IRAT. So after that, I allow them to discuss it and then come up with the answer. But that's something else. So there are accountability in IRAT. The students have to study before coming to my anatomy labs. Our IRAT counts for 10% of their final grade. So because, as I tell them very frankly, we don't want tourists there. If you're coming there, you should have done the preparation first before coming to the session. And we give them time to do it. That's the important thing. We don't bombard them with reading every night and then the next morning at 8 o'clock say, you have to have read this article before coming to my session. No, we give them at least 2 hours off the day before so they can go and read the preparation. But when you come, you do that IRAT, and that's going to count for your exam. So that's accountability. And the peer evaluation, I don't do it. And the reason is, it is part of the accountability, but I had more problems doing the peer evaluation than not doing it. When we started introducing team-based learning, it's a lot to sell to the faculty and the students. There were lots of people, and Alice is going, yes, probably you guys had the same thing. There are lots of people who don't like it. They're like, why are you not lecturing to us? Just spoon feed us everything. I don't want to prepare. Faculty is like, why are you preventing me to do my lectures? I have to just stand there and watch them now. And so, you fight your battles, and peer evaluation was something I lost in these battles, but I don't think I know accountability counts, and I think they're accountable by the way I tell them the importance of it and the IRATs we do. But we don't do peer evaluation, but it's challenging. The studies I did, peer evaluation always comes up as a challenge.
So I'll just take a host prerogative for a second. If you're lost as to what an IRAT or a GRAT is, then just scroll up the page and you'll find a brief description about what those means. And essentially, they are individual or group assessments. I want to transition to our third question. I think all of us here have drunk the Kool-Aid. We're excited by TBL. We're attempting for me, for others, you have established team-based learning in your curricula. The challenge, of course, is for some of our audience, they're looking at this saying, an interesting instructional method, but tell me about the resources required of faculty to implement. There's not a lot of detail in your report, but I presume that this required an increase from baseline of resources and time. And how did you convince your faculty that this was worthwhile?
So we limited the number of faculty who actually wrote the exercises, and you're absolutely right. It had to be faculty that was very motivated and had the desire to spend the time required to prepare a good module. I think for the faculty, when they saw the results of the sessions and how much learning, and I think they themselves, I learned a lot when I was making them up, and to the extent that the learning, it's repetitive. From one, starting with the foundational knowledge from the initial pre-reading and then using the clinical vignette, which is what we use for our interactive sessions, that the kind of learning you got from it and the reinforcement, I think that was something that kept us going. Alex, I don't know if you can add to that.
But I'm not sure if you're implying there's an increase in resources. So the same faculty member was in the room who, quote, might have given a small group facilitated talk to a group of residents. So the faculty member just had to be taught or introduced to a new role of allowing the learners to take over the group, and perhaps at the end, assuring a summation or a common learning point about a clinical case. So there were no resources additional except the champions of the TBL, which was about 3 faculty in the GME area that were the champions of TBL. One of our greatest challenges resource-wise was we have 2 sites for the resident teaching, and to assure there was parity at each site, because they're different sites, and even though they both have residents, to assure that there was parity, I think, was one of our challenges.
Ali, have you had any challenges with resources, with faculty engagement and buy-in?
Let's go 2 points. Like, from the faculty, we're talking the big leadership in the faculty, they like team-based learning, and I'll give you 2 examples. In anatomy, before having team-based learning, we had to have one, what we would call demonstrator per group. So imagine I have 168 students, even if you have 20 groups, that makes 20 people working individually. When you bring team-based learning, you can have 1 individual for 10 groups. So you have less, faculty members standing there. The second thing is in PBL sessions. Everybody does PBL. Dr. Cantu and Dr. Lalonde, who are in orthopods in charge of our MSK PBLs, decided to switch to team-based learning. So you can imagine, instead of having 21, 22 PBL groups, that's 22 orthopods leaving OR to come to faculty to teach for 3 hours, then again back another day for 2 hours. Now you have 2 experts that are doing it. So there are 20 orthopods that are back in the hospital, and these 2 are experts, so it harmonized their teaching also. Because before, 1 orthopod was ready, the next door, the other guy wasn't ready. No disrespect, it happens. So the groups were not getting the same type of information neither. And now that's solved. Now it has its own problems. I'm not saying it's perfect. The students have lots of complaints about how these sessions are going, not for the teachers, just the setting, how they're sitting in these rooms, this and that. So there are challenges about this, but the faculty likes it. Faculty feels that it can be affordable to do it, and the learning has been proven. Michelson have done many studies, and as Alice mentioned and Sandy mentioned at the beginning, collaboration, constructivism, all these have been proven methods of education. So education is there. I have the results from anatomy. The education is there, and this way you will need less faculty, and the teaching is at higher level, right? In taxonomy of Bloom, I'm bringing it higher. It's no longer memorization. It's no longer show me this artery. It's discussing a case that involves this artery. So in the taxonomy, it's higher education value also. So it was maybe hard to sell it, but if you base it on solid ground, you can succeed.
Let's move to our last question from our virtual journal club. Our hospital environments, for the large part, although we function in teams, much of the decision-making and management plans are done at the individual level, with contribution from other members of the team. But in other environments, certainly in the ambulatory environment, that distinction between an individual decision-making process and a group process becomes even more stark, favoring the individual. So is there a disconnect with a learning environment where we encourage and promote team-based decision-making versus an actual authentic clinical environment where the individual still, perhaps inappropriately, still has a lot greater autonomy? What do you think, Alice?
I think outpatient ambulatory services are more team-based than they used to be, where pharmacists are working together, PAs are working together, nurse practitioners are working together with clinicians taking care of patients. So I don't think it's as individual as it used to be. We have a current HRSA grant where we're looking at an interprofessional clinic model for primary care training, which is totally team-based in the care of complex primary care patients. So I don't feel that distinction. I think where it's more individual-based is in the private practice arena. That's where you probably see more individual, and it's not as applicable. But for the residents who are training in our clinical sites, I feel team approach to care is not absent. It's not exactly like on the inpatient unit, like we described, so vividly. It's just the way the care is. But I still think in our clinics there's an attempt to do some team-based care. Sandy can comment maybe a little more.
And I think even from a financial aspect now, too, I think we're moving more from a person-centric care to now a population-based kind of care. So value-based purchasing is a hot topic these days. And that to achieve the metrics of value-based purchasing, you really need a team. You have a team of people working on populations of patients to identify gaps in care and getting those patients in and getting them seen by a team. I think even financially, it's quite in line of where the healthcare field is going.
Ali, what are your thoughts?
I completely agree. Actually, even in undergrad and in postgrad and in healthcare, now interprofessionalism is huge. All the money that comes from healthcare in Canada or anywhere else, it comes from the same sources. So usually you want the best for the patient. And now everybody works in teams. It's interprofessionalism. And as you know, when we were at ICRE last year or the year before, Larry Lingard talked about competency as a group. That competencies like collaboration, communication, these things are much more important now because you're working as a group. So you need to start evaluating these as a group. And the best way to do this is team-based learning. I seriously am trying, and it's very hard to do, it's been years I'm trying to do this, is to bring nursing students into my anatomy lab when I'm teaching medical students, to put them, integrate them in my teams. In the anatomy lab, have medical students from the first year work with nursing students, work with physiotherapy students at the same time, so they learn in teams, so they, from the beginning, they don't feel like he or she. They don't feel that there's any difference. You're there to learn the best way, the same way when you go to the hospital, you're there to provide the best care for the patient as a team. I'm no longer an individual, I'm part of this team. If it works best for patient, that's the way it is. And these type of competencies, as I mentioned, collaboration, communication, scholar competency, these you can teach it right there from the beginning when they come in. So team-based learning can help with all of that.
I'm scanning my Twitter feed, and a number of individuals have picked up on Ali's theme. If interprofessional education is the big hot topic in health professions education right now, Sandy, Alice, is there thoughts of expanding the team from intra, meaning physicians, to interprofessional team-based learning to expand the approach to these common chronic illnesses that you educated your residents about?
Well, it's interesting that you say that, because with this HRSA grant that we just received, it's teams of psychology students, pharmacy students, medical students, and residents working together on a team. There's going to be education sessions that happen 3 times a year, and those sessions that happen in the year on topics that are relevant to primary care, we're thinking about doing team-based learning as one of the pedagogies, not the only one, but one of them. So that would be, if we carry this forward, and it hasn't happened yet, so I'm not committing to it, that would be team-based care with interprofessional teams. Currently, what we find with our nursing students, I heard Ali mention getting them into the lab. The schedule of our nursing students, we have a nurse practitioner program, is that they work during the day and go to school at night. The medical students go to school during the day. So coordinating the schedules of different disciplines is extremely hard. The PA students go to school during the day, which is good. The problem with the PA programs, they're very abbreviated compared to the other health profession programs. So their time that they have to get together with other professionals is extremely tight in the classroom setting.
I'm going to take our last question from Twitter, and then we're going to sign off. Sandy, it's an operations question. Your paper describes teams of 4 and 6. Is that the ideal size? Is there a ceiling, or is there a floor in terms of the size of a group makeup?
So you definitely want you don't want too small of a team. So I think 4 should be the minimum. At the same time, you don't want too much of a large team because the dynamics wouldn't be the same. So I think between 4 and I would say 8 would be a maximum for a team for this type of discussion. Alice, do you want to offer an opinion?
Dean Pomerly says 6 to 8. That's in his 12 tips article on medical teacher. 6 to 8 is the number. That's sort of good number for any small group. You know, below 6, you're not having enough diversity of opinion. So I think, you know, working in the 6 to 8 range for most small group work is ideal, and that's in the literature as a goal. And it's no different for TBL.
Before everyone starts to go to the PubMed and get on the internet, so we'll put that medical teacher paper in the show notes. Let's wrap up. Ali, any final words to the medical education, health professions education community around team-based learning?
No, it was a good experience for us. It's a great method. It can come out harsh at the beginning when you're trying to do it. But tblcollaborative.org is a very nice website that gives you lots of tools and everything. Be very careful if you're doing team-based learning or you're doing just flipped classroom. I saw a few discussion earlier today about why we're doing IRAT, why we're doing GRAT. Flipped classroom is another method of teaching that's very well accepted and everything. It's not team-based learning. Team-based learning has its own, you know, characteristics. So just don't mix the two up. If you can do flipped classroom, great. But if you want to do team-based learning, the recommendation, as has been mentioned by Alice and Sandy, is like there are, you know, many articles on medical teacher, the 12 tips, the one that you said you're going to put up and everything that explains exactly what team-based learning is. And the best way, I think Sandy said it at the beginning, you need to have your champions. I give workshop on team-based learning, I walk away, and then it's up to the people in the room to decide if they want to do it or not. But each university, each section, department, if they have their champions, they usually can put it together. There's lots of resources out there, and all the best.
I just want to say about resources, I think you're right. The TBL collaborative website, of course, is fabulous. The hardest thing, the most important piece of TBL to be successful and get buy-in is the application exercise has to be very strong. If your application exercise doesn't take the learning to the next level, then it all falls apart. So to me, that's just based on my experience. So in GME, it works beautifully because we take cases, and cases are always exciting and challenging. So that's very, very important with that. So in terms of having a successful operation, focus on your application exercise.
Sandy, you have the last word.
I'm going to second that. I think that's actually the biggest contribution to the buy-in from the faculty and the residents is that our application exercises were basically cases that the residents probably saw that week or the day before or probably even that morning, and having them see the application of that knowledge to a real life experience, I think that's what got us the most buy-in.
Excellent. Well, with that, we're going to wrap up our broadcast. I want to thank all of you for joining. I want to thank particularly our expert commentator, Ali Jalali from the University of Ottawa. And I want to thank our study authors, first author Sandy Baldwin and co-author Alice Fornari. The buzz on Twitter and at our site has been significant. Continue the conversation. We're going to close our virtual journal club Friday at 5 p.m. EST. you can continue to follow along at the hashtag JGME-Scholar, which presumably if you're on the broadcast you've already found that identifier. But that's not where the conversation will end. The Academic Life and Emergency Medicine editorial group is going to provide a synopsis and a summary of all of our discussions, and that will be published in a future issue of JGME, presumably in the next 6 to 9 months. So thanks for joining. Let's continue to talk offline, and we look forward to seeing work from this group in the future to challenge us as health professions educator. Take care.
Thank you.